Okay, in this video, I want to introduce some medications to deal with pain. So these agents are classically referred to as the analgesics, and it's sort of a wide group. I'm going to start with the narcotic analgesics, and then after that, I'm going to talk about the non-narcotic analgesics, which also are going to sometimes be called anti-inflammatory agents and antipyretic agents. So they're a little bit broader in scope. So when we think about drugs for pain first off, which is the classic drugs that we're going to start with, which are the narcotics, I want first to just introduce the term analgesic again, and I want to talk about the different classes of analgesic agents, and then I'm going to again focus on this video on the narcotics. So an analgesic is an agent that relieves pain without the loss of consciousness. So it's a more selective agent, as opposed to a general anesthetic, which is a drug that causes a loss of consciousness. So that's a true CNS depressant. We've talked about these before already previously in the form of benzodiazepines, barbiturates, and also ethyl alcohol. But in this context, we're looking at managing pain, and so we have sort of a broad armory of things to choose from. Pain management is one of the more challenging issues facing the clinician today. Pain is a subjective experience, and it's defined as an unpleasant sensation that can be either acute or chronic, and is the result of complex neurochemical processes in the peripheral and central nervous systems. So I mentioned it's a subjective experience, it's a perceived experience, and because of that, the prescriber is relying almost exclusively on the patient's perception and description of their pain, which makes for sometimes kind of a challenging therapeutic situation or clinical situation. So the different types of analgesics are usually divided into two big kind of overarching categories, one of which is the narcotics, where the opioids fall in. That's spelled incorrectly, sorry. And the non-narcotics. The non-narcotics, which we're not going to talk about in this video, but we will in the next one, are the salicylates or aspirin, the aniline derivatives of which acetaminophen is an example, and a whole bunch of other non-steroidal anti-inflammatory agents. So these non-narcotics are used for pain, but they're also used probably more frequently as anti-inflammatories and also antipyretics. An antipyretic is a drug that decreases the body temperature. So we'll come back to that later. But for now, I want to focus on the narcotics exclusively. So the narcotics are used for pain management. You can see some examples up there. There's a whole bunch of them. I'll show you some more examples later. Morphine is the prototype drug, and so I'm going to kind of focus on that one. Codeine is a little bit less potent. Meperidine is another opioid that has a longer duration of action. Okay, so I want to talk about these drugs in terms of how we would use them clinically, and then I want to talk about some side effects and toxic effects. And like I said, we're not going to get into all of the different options. There's the non-synthetic and the synthetic, which are going to be very similar in terms of their action. So I'll show you a couple pictures of those once we get going. All right, so we also have some antagonists. I believe we've talked about naloxone before. Naloxone is the most commonly used antagonist in the cases of opioid overdose. But we also have naltrexone, which is another drug that's used more frequently in opioid withdrawal. And then we have a partial agonist called Lorphan later. All right, so here is a picture of what's sort of going on here. So the main mechanism of action with these narcotics or opiates is they are going to be drugs that act at specific receptors in the central nervous system to reduce the perception of pain. So one thing to note about the opioids is they don't eliminate the pain. The patient knows that they still have the pain, but they're just not as bothered by the pain. There's 3 receptors that play a role here, only 2 of which are represented on this slide. The one receptor is called the mu receptor, which is this one here. That one's kind of the one that gets most, that one definitely produces most of the analgesic effects that we think about when we think about opioids. And then there's the kappa receptor, which also does do some analgesic effect as well. You can see both of them are going to see a decrease in GI motility, which is very common with the opioids. We'll talk a little more about that in a minute. The mu is the one that's responsible for respiratory depression. They're both sedatives. And the mu is also the one that we see more clinical dependence, or physical dependence, I should say. There's an additional opioid receptor called the delta receptor. And the delta receptor is more known for sort of the enkephalon binding. They're a little more peripheral, I guess we could just say that. So we'll come back to those receptors a little bit later. But the main effects or actions of the opioids are mediated through that mu and kappa receptor. So basically the narcotics or the opioids get divided into 4 groups. The pure opioid agonists, of which morphine and codeine are examples. Morphine is again the prototype, codeine's a lot less potent. Then we have mixed opioid agonists, which you can see 2 different types here. We also have antagonists, of which naloxone is an example. And there's also, which aren't on this slide, but there is a group, sometimes they get grouped into what we refer to as weak agonists or reuptake inhibitors. But we're not going to talk too much about those. Okay, so before we talk in detail about the narcotics, since they're both used as analgesic agents, it's kind of helpful to think about, well, when would you use one over the other? And sort of the going rule of thumb is that the narcotic should be reserved really for severe pain. They're going to act almost exclusively on the central nervous system, although they do have some peripheral effects as well. They're definitely associated with tolerance, which, as we know, you have to continue to increase the dose to keep the effect. They're definitely equated with abuse and physical dependence as well. The non-narcotics are going to act mostly peripherally, although sometimes a little bit centrally, and they seem to be more focused around the release of the prostaglandins, decreasing release of prostaglandins, which we're going to talk about on the next video. They definitely should be tried first for low to moderate pain. That's pain of things that are sort of chronic, like headaches, arthritis, peripheral pain, those kinds of things. Traditionally, they're not necessarily abused and they don't cause addiction. It doesn't mean they're totally safe. You can overdose on them, and we'll talk about that. But they're not generally abused, nor do they cause addiction. When we kind of think about the general mechanism of action of the opioids, we are thinking about the effect in a couple notable locations. So one thing we know about the opioid is that there are receptors in the central nervous system. We just discussed those. Also in the dorsal horn of the spinal cord and in the GI tract, as well as the urinary bladder. So we're going to see effects in all of these locations when opioids are on board. They decrease the release of substance P, which is a big player in the pain pathway, which we'll talk a little bit more later on. So by decreasing the release of substance P, that seems to modulate the pain perception as it's interpreted via the spinal cord. Also, the opioids appear to inhibit the release of many excitatory transmitters from nerve terminals that are carrying painful stimuli. So they have kind of an interesting effect. The big actions of the opioids are analgesia, also respiratory depression, which we'll discuss, spasm of smooth muscle in the genitourinary and gastrointestinal tracts, including the biliary tract, as well as pinpoint pupils. So I'm just going to expand on these things a little bit for a second, starting with number one, again, with analgesia. So again, morphine produces, and I'm going to use morphine as my prototype, although other drugs could be interchanged there. Morphine produces drowsiness and sedation, as you can imagine, in addition to the reduction in the awareness of pain, right? They still know there is pain, but they're not as bothered by it. Oftentimes, morphine, especially initially, does cause some nausea in some patients. And the thought there is that that morphine directly stimulates the chemoreceptor trigger zone in the medulla oblongata, which is kind of the vomiting center of the brain. We'll see that because of the same location, morphine also is an effective cough suppressant, again, because of the cough center located at the medulla. At the eye, one thing to remember about the eye is number 4 there, that morphine causes pupil constriction by a direct action in the basically at the oculomotor nerve. So this is the classic pinpoint pupil that you refer to in the emergency room when we're looking at opioid overdoses. And it's a very common presentation, whether it's morphine or heroin or what the opioid is, the pinpoint pupil. The respiratory depression is, again, a direct action on the central nervous system, causing direct respiratory depression. All phases of respiratory activity are depressed. And the breathing drive when the oxygen levels decrease is also depressed. In terms of the GI-GU, it's a very similar effect on both locations. And what we know is morphine increases the resting tone of the smooth muscle of the entire GI tract, which is really severely going to decrease the movement of the stomach and the intestinal system, leading to spasm potentially and also to major constipation. This is a big deal. Also, morphine produces spasm of the smooth muscle of the biliary tract as well, and there's tolerance here to morphine, but tolerance does not seem to develop to the constipating action, which means that they just continue to stay constipated. Oftentimes, we have to use drugs in order to relieve the constipation. The same kind of effect happens at the genitourinary tract, leading to urinary retention. All right, so let's look at therapeutic uses. So again, therapeutic uses, the relief of pain, that's one of the big thing. Really what the drug is doing is altering the brain's perception of the pain. It's not getting rid of the pain. We don't want to jump into this first, right? We'd start with something that's less potentially dangerous, abusive, or less likely to cause tolerance. And we would start with something like aspirin or acetaminophen or something along those lines. Some agents combine acetaminophen with the narcotic analgesic. That's what Percocet is, or Percodan. Those combination of codeine, which is an opioid, with some sort of acetaminophen or some kind of another analgesic agent. So relief of pain is probably the most common use of morphine. We can also use narcotics as antitussives. This morphine is too strong for this, but codeine would be a good example here. It's just against suppressing the cough center, right? And codeine's much less potent than morphine, so it's going to be safer in that respect, but it's still going to cause the GI, the constipation, potentially the urinary retention. Diarrhea is another therapeutic, or you could use opioids therapeutically if someone has diarrhea. There's other things to try, but these really will work quickly. Oftentimes, they'll use, again, another anti-diarrheic agent with opioid in order to kind of slow down GI motility really quickly for a short-term period of time. That's what paregoric is. The active ingredient is a narcotic. And the direct action is inhibition of the gastrointestinal motility. Okay, in terms of side effects of these drugs, nausea and vomiting I already mentioned. and that usually seems to be more reserved for the first doses. Respiratory depression, we mentioned as well. Constipation, unless you're trying to use the drug for that, you got to know that they're going to have constipation for sure, is a big issue with narcotics. We see some behavioral changes. You can see they're kind of all across the board, but restlessness, excitement, tremors, delirium, insomnia, all of these would be a possibility with opioids, and also could indicate that this patient could use a different type of pain reliever. Histamine release is kind of interesting. Morphine causes histamine release. It can cause bronchoconstriction, so in asthmatic patients or allergic patients, we might want to be careful. And physical dependence is a big thing. The withdrawal symptoms seem not to be as serious as with barbiturates, which is surprising, but they are quite common. The side effects, the main side effects, I think are going to show up here. Yeah, there they are. So before I talk about withdrawal and side effects, I would like to mention that for a few cautions. So if someone already has depressed respirations, then we wouldn't want to give them a narcotic. So if they already have a depressed respiratory system because they have emphysema or some other more likely chronic obstructive pulmonary disease that causes depressed respiration. Also, anyone that has had a head injury, head injuries, especially if there's any swelling, are one of the worries is that we'll see respiratory depression, mostly due to shifting of the brainstem with the swelling in the brain. So we don't want to give somebody a narcotic that has had a head injury that may or may not be, may possibly lead to respiratory depression and or decreased awareness. It's going to be hard in those situations to be able to isolate whether it's the drug that's causing some of the symptoms or it's the injury. So that would not be a good choice in this case. The withdrawal symptoms. Okay, so like I said, these drugs produce tolerance for sure. The main withdrawal symptoms of opioids are going to come on relatively quickly, and there's sort of this weaning off period with opioids. The common adverse effects are going to be these are just adverse effects. Low blood pressure. We mentioned the dysphoria or the anxiety, depression, that kind of feeling is common. Sedation, constipation, I already talked about, urinary retention, nausea, potential for addiction. But when we start to think about actually withdrawal symptoms, the withdrawal symptoms that we see with opioids are going to generally last for upwards of about a week to a week and a half. And it's going to start with chills, hot flashes, tearing of the eyes, runny nose, sneezing, drowsiness, and yawning. But they can get quite a bit of anxiety. Also, a lot of muscular abnormalities like twitching and cramps of the muscles, especially the muscles of the stomach, the back, and the legs. Vomiting and diarrhea are pretty common. Dilated pupils, elevated body temperature, increased pulse, and blood pressure. Generally, the withdrawal symptoms are going to last for somewhere between a week to 10 to 10 days. And generally at that point, the physical dependence is gone, keeping in mind that conversation we had around tolerance, that people need to know if they wean off of these drugs after the dependence is gone, they're also lost their tolerance. So if they, and this is again can be in the case of abusive behavior or reasonable use, they don't want to go back to the dose they were last at, because that could be potentially way too high. They would, be back for starting fresh, almost as if they're an opioid naive at that point. So this withdrawal picture can last, upwards to about a week and a half, but usually the worst of the symptoms are over in a couple days. So that's kind of the long and short of the narcotics, keeping in mind that these are agents used for pain, that pain is a perceived experience, that the prescriber has to rely on the patient's perception and report of the pain. And really these drugs, because of this issue with abuse of opioids, which is huge, I was reading somewhere, and now I don't know where exactly I read it, but it was around abuse of these drugs and how common, and that the prescription writing for opioids, really has gone out of control, and that we really need to be aware of this issue. I guess that's enough for this class. I do want to, again, just mention the antagonists. We've talked about them before. The two big ones are naloxone and naltrexone. Naloxone or Narcan is used to basically bump somebody out of either the coma or respiratory depression if they've overdosed on an opioid. Usually happens pretty quick, within 30 seconds of injection of naldoxone. Naloxone, the respiratory depression and the coma is reversed. It's pretty crazy, causing the patient to be right back in the game, totally revived and alert. The other one is naltrexone. Naltrexone is more oftentimes used in the management of somebody coming off of opioids, so more of a like a opioid withdrawal sort of symptom, not necessarily an opioid overdose. Okay, so after this video, I want to come back and I want to talk to you about some other analgesic agents, both for pain as well as inflammation and decreasing body temperature. I will see you in a little bit.